out in the hinterlands elsewhere. SHYAM JOSHI nicely came up here to present in person this year. I personally like it when we have sessions in person, just to look at people in the eye and not just be sort of remote on a computer somewhere and wherever. A condition that I don't think we had named. We didn't exist when I was where the fellows are now. Nobody had ever heard of FPIES. I certainly hadn't, which has grown into a fairly major topic now as a non-IgE mediated, to me, somewhat mysterious disease. First just described in kids, now, as you'll hear, in adults as well. So thank you. Let's go ahead and get started.
All right. Well, thank you all for coming in person. And yeah, I've done this talk, I think, 2 years in a row coming into this year, and it was all virtual. And so when I had the opportunity to drive up here, I somehow didn't hit any traffic yesterday and got up here in 3 hours, which is definitely a record. Oh, let's get rid of this screen because this is annoying. How do we get rid of that? We'll just do that. All right. So we're talking about FPIES today, and 1 hour isn't enough to talk about everything that you need to know about FPIES. So I'm really concentrating on updates in the past 5 years. So there'll be some hopefully new stuff here, and a little bit of review and just digging into the data a little bit more, because as Dr. Altman said, is 5 years ago, we didn't really have a lot of this, but a lot has happened in the past 5 years. You guys can read the objectives later. Disclosures, none of these are relevant to FPIES because there's really not much about FPIES out there. And outline-wise, we're really going to talk about historical context, epidemiology, spend a decent amount of time on adult onset FPIES, which I don't feel like enough of us look for. When you look for it, you will find it. And then updates on pathophysiology, because there actually are some updates on pathophysiology, which is exciting. And then kind of the use on ondansetron. I'm going to use a polling system kind of throughout the talk today just to keep a little bit more engagement. Otherwise, 7 o'clock is pretty early. So if you have your cell phone, there'll be QR codes that come up there. You just scan the QR code and you can answer the questions, and we can do this live, including the people who are there virtually. You can also participate in that. We can get a polling for everybody that's involved. All right, so quick definition. FPIES is a non-IgE mediated food allergy characterized by delayed gastrointestinal symptoms following ingestion of the culprit food. I think we all know that, we all understand that. But there are some subtypes, right? There's acute FPIES, which is what we're going to concentrate on today, which is the 1 to 4 hours after ingestion, you get the repeated vomiting with a few other symptoms. Chronic FPIES is pretty much in the infant age group, and it's almost exclusively in formula-fed infants, whether that's cow's milk formula or soy formula. And these patients often get intermittent vomiting, a lot of diarrhea, and the diarrhea is not just regular diarrhea. These are often contain blood, mucus, and often present with failure to thrive. And then atypical FPIES is when a patient comes in with FPIES symptoms, and you do IgE testing on them, and they're also IgE positive. So they both have IgE sensitivity and a history consistent with FPIES. And why that's important, we'll talk about briefly. This is from the 2017 FPIES guidelines. And we're not going to go into this too much detail, but they do try to categorize acute or FPIES in general in a few different ways. When onset started early and late, I don't find this useful at all. I don't think it actually makes a difference until somebody proves the otherwise, but I don't really call it early or late FPIES. They have mild to moderate and severe. Sure, you can categorize it that way. It may help make some decisions on when you're going to challenge these patients afterwards, but otherwise, it is what it is. We talked about acute versus chronic, and then we talked about atypical FPIES when you have IgE sensitivity in addition to the FPIES history versus classic FPIES where you do not have IgE sensitivity. So acute FPIES has this diagnostic criteria. Do I pull this up every time I diagnose FPIES? Absolutely not. Most of the time, these people are pretty straightforward, pretty obvious, but technically, based on the guidelines, you have to meet the major criteria and 3 of the minor criteria. And when you look back, most of the patients that you're diagnosing with FPIES do meet at least 3 of these minor criteria. really the repetitive vomiting on after eating a different food or the same food. The lethargy, the pallor. Sometimes you get diarrhea about 50% of the time, 5 to 10 hours later. And then obviously if you go to the ER, require IV fluids. So maybe everybody doesn't fit perfectly into this definition, but most of the time you're going to be able to diagnose them whether you use the major or minor criteria. So let's look at a timeline for FPIES. So this was first described back in the 1960s. And so Powell and colleagues described this phenomenon of young kids, infants, drinking cow's milk or soy formula and vomiting. But they didn't know what to call it. So they actually often called it necrotizing enterocolitis. They called it sepsis. They called it a bunch of different things. But looking back now, it fit the criteria of FPIES. Fast forward about 20, 30 years, and in the 1990s, we're starting to see, okay, it's not just cow's milk and soy. You can also get it from solid food. So this is when rice and oats started becoming more common, poultry, some other legumes. We're also seeing it in older kids. It wasn't just infants anymore. So at this point in the 1990s, 2000s, we're thinking this is a childhood condition, doesn't go into adulthood, and that's about all we knew. And then in 2010s, specifically 2012, was the first challenge-proven adult FPIES case, and that was to scallops in England. And so now we understand, okay, it's not just kids, it's also adults, and the food variety has significantly changed. And you can see on here, you have peanuts. So if you look back at the Mount Sinai data back from 2001 to 2011, they had 0 cases of peanut FPIES. And then you had the LEAP study and you had the early food introduction in the 2015 timeframe. And now they have peanut FPIES is not that uncommon. They reported over 14 cases in 2019 and 2020 alone. So a lot of it depends on what foods are being introduced, whether that's culturally around the world. So fish FPIES here in the US is extremely uncommon, but fish FPIES in Europe is fairly common. It's actually the second most common cause after cow's milk. So a lot of it's depending on how food is being introduced. All right, first survey thing. So if you just pull up your phone, scan the QR code, this will pop right up in your browser. But what is the prevalence of acute FPIES? And we're saying global prevalence. Give you guys a minute. Working for everybody? It doesn't tell me how many people have responded, so. I think everybody else is done, but. All right. Time's sake, we're going to move on here. So yeah, most people are saying about 0.5%. And I think that's generally the consensus, kind of a little bit all over the place. We don't really know. There aren't any significant large-scale epidemiologic studies. There's a ton of selection bias. Almost all cases of FPIES are in academic settings. We don't really know what it is in the community. And most of these are retrospective. And with the various definition of FPIES, and especially anything before the 2017 guidelines were published, FPIES didn't really have a solid diagnosis. So was it acute? Was it chronic? Was it classical? Was it atypical? There was a lot of definitions here that were at play. So I don't think we really know, but we do have some data. And so there are a few countries that have we've had some studies from a few countries that have shown the prevalence somewhere in the 0.3 to 0.7 range. So Israel had 0.34, Spain 0.7, Australia, this is more the incidence, is 0.015% per year. And US 0.51, so right on what most people had put in the poll. And in US, they also have adult data, and it's around 0.2% of adults may have acute FPIES. And in Sweden, about 0.45% of children. That's a really new study that came out just a few months ago. So yeah, I would say we're seeing acute FPIES in about 0.5% of children. So some general clinical characteristics: slightly male predominance, which is something we see in general food allergy as well. A lot of these patients have concurrent atopic disease, so somewhere between 20 and 77%, which is a huge range, but more so than the general population. And then IG sensitization happens in about, I would say about 15 to 20% of patients. And we'll talk a little bit more about why that matters.
Sensitized to the same food.
Yes, sensitized to the same food. Yes, sorry. IG sensitization to the same food that they have the FPIES to. And 75% of cases occur in the first or second ingestion. This is a little bit older data. If I would say in my clinical practice, I'm seeing more and more patients, second, third, fourth ingestion of the food that they're getting the FPIES reaction. So I'm not sure if the 75% is still holds true at this point. And the age of symptom onset really correlates with what food is being introduced. So if it's happening at a very young age, it's usually cow's milk or soy, because that's what kids are introduced to, usually median age of 3 to 5 months. And then solid food FPIES are a little bit later, because we're introducing solid food a little bit later. So somewhere between 4 to 7 months. So what foods are associated with FPIES? So the next few slides are based off of a meta-analysis done in 2013. And then I'm going to show you one in 2023 and point out some differences that things have changed in the past 10 years. In general, in 2013, the vast majority of cases were milk, and second was soy. And that's different than what it is now. And grains, eggs, kind of everything else that we see causing FPIES. If you break down the grains a little bit further, you have rice and oat are the most common, but wheat, corn, barley are also in that system. When you look at meats, fish, peanut, and tree nuts, you have poultry being kind of on the higher end. But if you look at the percentages, it's a different scale, right? It's a very different scale. So poultry is still not that common, but of the poultry, chicken and turkey and beef are the most common. And you can see all the way down here, peanuts, kind of towards the end, not a ton of peanut FPIES back in 2013. And vegetables, again, sweet potatoes, one of the more common ones, which is what we ask our patients, but peas, potatoes, pretty much any kind of vegetable can cause FPIES. And when you look at fruits, banana is the most common, but some of the other fruits are also implicated. And when you look at which foods can cause FPIES, it's pretty much every food. Any food can cause FPIES. There are some that are more likely, but really any food can. And the number of food triggers is also interesting. So this is also from that 2013 meta-analysis that about 60 to 70% of kids only had one FPIES food trigger. But that also means that around 30 to 40% of kids had multiple food triggers that caused FPIES. And I think that's what most parents are terrified of, is they have one FPIES reaction, then they stop feeding their kid. And they won't feed their kid until they see an allergist. And sometimes for us, it's like, they're not gonna see us for 6 months. This kid hasn't eaten anything for 6 months, which is really the worst situation ever. And so really giving them guidance on how to introduce low-risk foods to high-risk foods is key here. This is the newer meta-analysis, kind of systematic review that happened just last year, middle of last year. And they looked at all the literature, including for the past 10 years, and found a little bit different ratio of which foods are most common compared to 2013. And so if we take these specific countries, you still see cow's milk is number 1 in all of these countries. But there are several countries, including Australia, Greece, Japan, and Spain, where cow's milk isn't number 1 anymore. And so you see fish in a couple of these European countries, then you have rice in Australia and egg in Japan, but number 2 is cow's milk. So cow's milk is still pretty common overall, but not necessarily the number 1 culprit across the globe. And then they aggregated all their data, and they found that cow's milk is still number 1, but like I said, fish has become much more common as a cause of FPIES. Not so much again in the US, but major parts of Europe and Asia, fish is much more common. And then you can see at the very end here, you have soy. So soy is no longer the second most common cause of FPIES. And the main reason is most pediatricians don't recommend soy formula as the alternative if there's issues with cow's milk formula. They go to hydrolyzed formula now. And so, especially in kids that are having digestive issues, if they have IG-mediated allergies, if they have FPIES, whatever, they're often switching to extensively hydrolyzed formula. And so kids aren't getting exposed to soy at a young age. And if you don't get exposed to soy, you can't really develop FPIES. So it's pretty much, it's dropped off significantly at this point. So let's go back to the peanut story. And so back before 2015, less than 2% of the cases of FPIES were really peanut related. Then LEAP happened. And so we're seeing this earlier introduction of peanut. And so this was a study out of Sinai that looked at their 45 patients that had peanut FPIES. And you can see that most of these kids' first ingestion was right at 6 months, which is the general recommendation. Even though you could make the argument that it should be earlier than that, but right now it's 6 months. And you can see the time of first reaction was right at 6.5 months, and the median age of reaction was 8 months. So a couple months after most of these people are introducing the food. And again, you see here that 40% of these patients developed peanut FPIES at their third or later ingestion. This is what I was saying earlier, is that I don't know if it's really first and second ingestion at this point, that you're seeing a lot more patients that have had it multiple times, and the parents are just flabbergasted. They don't know why it happened all of a sudden. I don't think we know either, but it can happen, and just reassuring them that that's not uncommon. And again, this is just recognizing again that milk soy co-reactivity that we've always been told that, hey, if somebody is allergic to milk, they're very likely to also have an allergy to soy, really doesn't hold true anymore, because they're not getting that soy exposure early in life. And so there's that co-reactivity was just incidental before, and it's really gone now because we're just not using soy formula nearly as much.
That makes it, do pediatricians know about this condition? Or is this something just allergists know about, and the rest of them know the kid is sick, but they have no idea what it is?
It's still hit or miss a little bit. I think it's also equally important for ER docs, because a lot of these patients are presenting to the emergency room, and the ER docs are like, I don't know. I would still say it's under-recognized. And often for my FPIES kids, I print out a letter for them and tell them to hang on to it. So if they ever have to go to the ER, they just give it to the ER doc. Otherwise, a lot of the ER docs, especially if it's not a pediatric hospital, they don't know what this is. And they don't know how to treat it. They give them steroids, they give them epi, and it's like, it's not really how we want to treat these patients. But most of the families are aware and understand the condition a lot better, so they can actually kind of guide the treatment if needed, which is not ideal. So I think it's still our job to get this out to the pediatricians, to the urgent cares, to the emergency rooms. I think GI docs are picking up on this pretty well now. In general, they do send a lot of patients over to us because they're like, we're not going to challenge them or anything, but they do at least diagnose it and let the family know to avoid it. So out of this paper, there was a really good quote that I just wanted to put in here. So early introduction of food triggers may coincide with higher vulnerability to FPIES. So as we're starting to push, hey, let's reduce IgE-mediated allergies by eating foods earlier and earlier and earlier, we're probably going to see an increase in FPIES to those foods. But I would say the vast majority of allergists are going to say that trade-off's worth it, right? If we can reduce IgE-mediated allergies that they may be stuck with for the rest of their life versus, okay, they had FPIES for a few years, they're going to outgrow it by 3 to 5. That's probably a really kind of worthy trade-off that any of us would take. Just a quick word about breastfeeding. There are rare case reports of both acute and chronic FPIES to exclusively breastfed infants and even extensively hydrolyzed milk. These are rare. These are very rare. But it does show that there may be that even small amounts of protein that's ingested by the mother can get to the baby, which we know is true, and that even that small amount may be enough to trigger an FPIES reaction. So we'll come back to this. When we do challenges, we often challenge these kids with massive doses of food. Is that really necessary if they're getting reactivity to pretty small amounts? So the natural history of FPIES really varies. And a lot of these countries have done their independent studies in their respective regions, and the data is kind of all over the place. This is a really great figure out of a paper by Drew Bird that came out in 2021. And it shows that different foods have different resolution rates for different populations. And there's a lot of factors here, a lot of factors in terms of how often were they getting exposed, how rigid the system is. In the US, we often don't challenge these kids for 12 or even 18 months after their last reaction because we don't want the kids to react. While South Korea, they are very aggressive. They challenge these kids 3 months after their last reaction. and they're showing resolution rates much earlier than we are because they're catching it earlier. Is that trade-off worth it? I think you can argue both ways depending on the family. So again, this meta-analysis that came out last year, they also took all the data and looked at what's the age of onset for most of these foods for these kids, and what's the age of resolution if those studies had that information. And you can see kind of the gray box at the bottom here. Most of these foods are pretty early in life, especially with milk being the earliest. And some of the solid foods like fish and egg are a little bit later because they're being introduced a little bit later. But the one thing you want to point out here is this fish bar up here. And you can see it's much higher than the rest of them. So resolution of fish FPIES is significantly later. In general, about 85% of kids will outgrow their sensitization by 5 years of age. But for fish, the average is 7 years. So it's a little bit later, not terribly late, but a little bit later. And for cow's milk, it's even earlier. The vast majority of kids will outgrow it by 3 years of age. And so it varies based off of the food, and we don't know why. All right, so as promised, let's go back to atypical FPIES. So again, atypical FPIES is their history is consistent with an FPIES reaction, but when you do allergy testing or skin testing or in vitro blood testing, you find that they're also sensitized to that same food. There were some earlier studies back in the kind of 2010s that suggested that if you had both sensitization and a history consistent with FPIES, that's going to last longer. That FPIES allergy is going to last several years longer, and you should probably delay doing challenges on these kids because it's going to stick around longer than the kids that aren't sensitized. But this study, this is out of Greece, and they took 100 patients over prospectively from their referrals, and that ended up being about 0.7% of their referrals. And they found that fish was the most common culprit food, followed by cow's milk and egg. And over that 10-year period, only about 50% of these kids actually outgrew their fish FPIES. So again, fish is a little bit later. 15% of these were found to have IG sensitization, so 15 out of the 100 kids. And they found no correlation between when they outgrow their fish FPIES, if they were sensitized or if they weren't sensitized. So maybe there isn't really an importance in doing allergy testing. I think people could have made the argument that, hey, I'm going to go ahead and allergy skin test you or in vitro blood test you to know if this is going to last longer or not. But I think the data now is a little bit murky and not sure if doing allergy testing really provides any useful information other than if they've avoided it for many years and you're going to reintroduce it just to make sure that they're not IG sensitized, and it may change how you challenge these kids.
If you're IgE sensitized, how does your immune system know whether to give you anaphylaxis to the food or FPIES to the food? Huh?
Both.
Both.
No, or neither. Exactly. We don't know. But I think it's probably follow the same kind of guidelines as we do for IgE-mediated food allergies. If it's minimally sensitized, a lot of these kids are going to tolerate it. If they're highly sensitized, then maybe a little bit less likely. But no, I don't know.
I didn't think you knew. I don't know.
All right, let's switch over to oral food challenges. So there was a work group report that came out from the Quad AI back in 2021, which hopefully some of you guys participated in. If you guys ever get a survey from the Quad AI, please answer it. Nobody ever answers it. And the data is always difficult to interpret. So it takes 5 minutes. Please just answer it, knock it out, because it is super useful for whoever's putting the survey out. So this survey looks specifically at oral food challenges for FPIES, and they found that 96% of providers perform oral food challenges in their clinic, but only 59% of them perform it for FPIES. So, okay. Then they looked at where do they perform these FPIES oral food challenges, and the vast majority, over 60%, were in their just regular office area. Some still used inpatient, the inpatient unit, and a lot of them depends, right? If it's a severe reaction, maybe I'll admit them and do it that way. If it's not, if it's a mild reaction, maybe we'll do it in the office. And if you look at the very bottom here, you got home. So some people are just doing FPIES challenges at home. There is some data suggesting that may be okay in certain situations. A few groups have published that just looking at these patients who had FPIES early in life and just following them over time, a lot of these families are just accidentally or naturally challenge their kid to FPIES at home. And most of these kids tolerate it just fine. And so you could make the argument that if they live really far away, but they're close to healthcare, and they had a very mild reaction, that you could have a discussion with the family with shared decision making that it may be reasonable in very, very, very select cases. And then they also ask who puts in a peripheral IV. Just to show of hands, like who puts an IV every time that they do an FPIES challenge? Nobody. I think that's pretty much the consensus at this point. But back in 2021, you had over 25% of providers saying they're going to put an IV in every time that they're going to do an FPIES challenge. I think the majority of people, it depends. I've done it once in the past 5 years, and that person did just fine. But really, I did it for the parents because the parents were so scared that this made them feel better, that they had an IV access in, were ready to go. But obviously, my practice is biased. We're at OHSU, we're on the Hill, we are attached to the hospital. So if anything happened, we can just call a rapid response and they'll come over and place an IV for us really quick. So I think in private practice, it's definitely a discussion, but a lot of clinics don't have nurses that, or even providers that feel comfortable putting in IVs in a 1-year-old. And so that's also a limitation why a lot of providers don't feel comfortable doing FPIES challenges in clinic. All right, next survey question. So what is your target dose for FPIES food challenges? Are you given 10% of the regular amount, 25%, 50%, or full amount for serving size for the age? We have somebody on chat. Mixed practice BC, but increasing number of us are doing home FPIES challenges. Yep, see, can absolutely happen. That's Victoria Cook. Yeah, I think Canada is usually ahead of us in general, so.
This year, the first time people in BC started joining.
Yeah, it's fantastic. That's absolutely fantastic. All right. Let's see what people have said. Regular serving size, 10%, 25%, 50%. Okay. I think this is probably pretty accurate to what's happening around the country. At OHSU, we still do the kind of regular serving size that we would do for IgE-mediated allergy food challenges, but that may not be the right approach. So going back to that survey in 2021, they also asked what total dose administered are you administering during these FPIES oral food challenges? Most people are saying the regular serving size, exactly what most of us are doing, and based on grams of protein per kilogram, and that can range. Most people use around 0.3 to 0.6 grams of protein per kilogram body weight. And so that's what most people were doing 2 or 3 years ago. They also just asked what interval are you using during these challenges? You're doing it all on one single portion? Are you doing 2 equal portions over 30 minutes? Doing 3 equal portions over 30 minutes? 5 incremental? So there's a lot of different ways that you can do this, but a lot of this is probably unnecessary. So there have been a few studies in the past 5 years that have looked at, let's challenge this kind of traditional protocol. And let's see, is there other ways we can do this that are more efficient, that are easier? And so this is one that I'm highlighting out of Italy. And they took 48 of their patients, 54 challenges total, because I think 4 of the kids had multiple foods. So they did multiple different challenges. And their protocol was, hey, we're going to give 1/4, so 25% of the regular dose, the amount that appropriate for the age. We're going to wait 4 hours. And then if they don't have a reaction, we're going to give them the other 3/4 and wait for another 4 hours. This sounds terrible in clinical practice, having a kid wait around for 8 hours, but I'm glad they did it because we have this information now. So they found that 19 of these patients had a positive challenge with a mean latency of around 136 minutes, so a little bit over 2 hours. All 19 of these occurred with the 25% dose. There were no kids that tolerated the 25% and then didn't tolerate the full dose. And there's some other studies that have also looked at this. Some have done a quarter, some have done a third, so 33% of the service dose. And the vast, vast majority of the time, you're getting the reaction at that nominal dose and not having to wait for the full dose. It's not perfect, but the vast majority of situations, that's what's happening. And most of these reactions that happen at a lower dose are generally milder as well. And so in this specific study, most were mild to moderate. About 75% of the time they used ondansetron. They also used steroids, which I think a lot of people are going away from in general. Very few needed IV fluids. None of these patients needed ICU admission. So again, this paper that came out by Drew Bird and several of his colleagues in 2021, they came out with a few suggestions. This is, again, expert opinion. We need a lot more data to probably finalize this, but doses of 25 to 33% of the standard serving size is probably sufficient to trigger a reaction in the vast majority of patients. So do we need to use a full serving size? Probably not. A lot of the times where we get hung up on and not being able to complete the challenge is a kid just won't eat enough. The kid refuses to eat. They eat maybe half of the amount, and then we say we can't say this was really a success because they didn't actually eat the full amount of food. But maybe we don't need a full amount of food and they just need a small amount, and we can say you're fine, you're good to go. There's little benefit to offering divided doses over an hour unless there's evidence of an specific IgE present as well. And the main reason is these challenges, they cause reactions 2 hours later. Why are we separating the doses within an hour? It doesn't really make sense. Let's just give it to them in a single dose and they're fine. And if we need to satisfy our 95076 code, we give them in 2 separate doses a couple of minutes apart. So we can give that incremental doses so we can actually bill for it properly. Reactions, again, typically occur within 4 hours. So doing a challenge longer than 4 hours is usually unnecessary in the vast majority of cases. And these reactions rarely result in emergency ER visits or ICU admissions. And so these are generally safe to do in even general in community practices. And IV access isn't necessarily needed in most of the time.
I mean, you're only challenging people who had a clinical story consistent with FPIES. So what do the rest of them have if the challenge is negative and yet they had a clinical history that matched FPIES?
Yeah, most of these studies are actually in kids that already had confirmed FPIES and they were challenging them to see if they've outgrown it.
So sometimes they had a positive challenge.
Yeah, they either had a positive challenge or just a really good history on multiple times to the food, and they didn't necessarily need to challenge in that situation. But that's where most of these studies are, is that these are already confirmed. These are checking if they've
now tolerant.
Exactly. All right. All right, we're going to shift over to adult onset FPIES. So again, not until about 2010, 2012 did we realize that there could be an adult version of this as well. And so this study, I believe it was out of Spain, but don't quote me on that, is a European study. And they looked at their population of adult onset FPIES and then followed them over time. And interestingly, they identified 42 patients and 83% of them were female. Versus what we talked about earlier in pediatric FPIES, it's majority male. So, okay, there's a shift in demographics here. Age of onset first reaction was around 40 years of age. And they looked at which foods were implicated. By far, most common is fish and shellfish. That kind of mimics what we see with IgE-mediated allergies in adulthood as well. But you can see some other foods were also implicated here. And many of these foods were early on in the latency period. It kind of was 2.8 hours, which is pretty consistent with pediatric FPIES. Then they looked at, okay, let's take all these patients that we had and what were their presenting symptoms. And it's different, right? Pediatric FPIES is pretty much vomiting and then everything else. Here, only about 60% of these patients had vomiting as their major symptom. They had nausea, and then diarrhea was their big one, 93%. And that is pretty similar to what other studies have showed looking at adult FPIES. There's a Canadian study that came out and they had 100% of their adult onset FPIES had diarrhea. So that diarrhea is going to be the bigger component here. They often have abdominal pain, abdominal distension. I know you guys are thinking this, because I'm thinking this still. Is this the same condition? Is this the same thing as acute FPIES in pediatrics and adults? And there's just enough difference here. I think there's some clinical characteristics that are the same, the timing of the symptoms, and some of the mainly GI manifestations, but it's not exactly the same. And when you look at the pediatric population, while there's no great biomarker, we can look an elevation in white blood cell count. We can see slight increase in neutrophils. In adult onset FPIES, you don't see that at all. You don't see that same inflammatory pattern. And so could this be a different condition? And I'm giving this talk 10 years from now, and it's like, yeah, we were dumb back there, and this is totally different. I don't know. But right now, this is being called adult onset FPIES, and I can see enough of the similarities of why this will probably continue to be called this, at least for the immediate future. They follow these patients over time, and of the 42 patients, 36 of them never reached any kind of tolerance, but 7 of them did, and it didn't really make sense which foods were more likely or which foods are less likely. There wasn't enough patients here to really make that inference, but it seems like over time, adult onset FPIES, they're less likely to outgrow versus pediatric onset FPIES, but we need a lot more data to really make that statement. So there's a ton of research gaps in adult onset FPIES. We don't really know what the incidence and prevalence is. There's one study that showed about 0.2% of adults in the US. Mechanistic studies looking at pathophys, tolerance development, looking at, is our diagnostic criteria for acute FPIES appropriate in the adult population? I would argue no, it's not. We probably need a separate diagnostic criteria for adults. And then management is, can you manage these patients the same way as we do in pediatric cases? I don't know. Maybe, maybe not. See how we're doing with time. Okay. So I think this is the most interesting part of the entire talk, is looking at the pathophysiology of what we did know and what we kind of know and what's being suggested right now of the mechanism that's causing this. Still very poorly understood. We know that there's some non-specific gut inflammation that it leads to increased gut permeability. We do see an increase in macrophage activity, neutrophils. Eosinophils are not as important in this inflammatory pattern. We do see elevated levels of IL-8, 10, TNF-alpha, IL-1 beta, and we do see an increase in tryptase activity as well. So mast cells are somehow playing a role in all of this. Antigen-specific T cells have been reported to be present, but that's really mixed results because some of the studies show that they are present, some they don't. So unclear how important they are. But most importantly on the slide is that the humoral immune system has minimal involvement. So we don't think IgE plays a big role here, or any part of the humoral immune system play a big role in triggering FPIES reactions. So this was a really neat study out of the cyanide group as well. And what they did was they took 20 patients that already had confirmed FPIES, and they took the first 10 of those that they challenged and that had tolerated or outgrown it, and then the next 10 that reacted to the oral food challenge. They took blood work before the challenge, and then if they didn't react, they took it 4 hours after the challenge. If they did react, they took blood work at the onset of symptoms and then 4 hours later. So what they wanted to do was they wanted to look at metabolites and just kind of pan assess them and see, are there specific metabolites that are increasing during positive food challenges versus not happening during negative food challenges. And so they were able to identify 31 metabolites that increased during positive challenges. Okay, great, super helpful. But when you look into that a little bit more, 2 of the ones that were significantly elevated here was inosine and urate or uric acid. And why are those 2 important? Inosine has been implicated in gut barrier health, and so an increase in that could cause increased permeability. But more importantly, they're both part of the purine pathway. And I know this still gives me nightmares from med school and like undergrad biology. And I can't even, I don't completely understand this anymore. But I want to highlight 3 things here. You have inosine, you have uric acid, and part of this whole purine pathway system is adenosine. And we'll come back to adenosine in a second. So we're seeing this probably increase in purine pathway, just purine synthesis, whether it's de novo or salvage. We're seeing this increase in this general pathway. So going back to the study, they also found an increase in 5-hydroxyindole acetate. This is a breakdown product of serotonin. And so they're saying, okay, in those patients that are symptomatic, they had an increase in serotonin release, probably that's leading to the breakdown products during a reaction. Okay, so we have an increase in 5-hydroxyindolyl acetate. You have an increase in purine synthesis, which adenosine is important there. Then the next step that they did is they took biopsies from patients without FPIES or any kind of GI issue, from the stomach, duodenum, and the colon. And they stimulated them with adenosine, so stuff that's being produced in the purine pathway. And they found that the GI tract causes an increase in serotonin production with adenosine being added to it. And you see this in the stomach and you see this in the duodenum, but you don't see this in the colon. So does this increase in serotonin in the upper GI tract at least partially explain why most patients get upper GI symptoms with FPIES and not lower GI symptoms? So why is serotonin important? So this is a really neat study that came out 2011, I believe, and they're looking at rotavirus. And so we know rotavirus can cause a lot of GI manifestations, a lot of nausea, a lot of vomiting. And so what they were able to show is that the rotavirus actually stimulates these enterochromaffin cells in the GI tract to specifically release serotonin. And when the serotonin is released, it binds to the serotonin receptor, which is 5-HT3 right here, and leads to going up the vagus nerve and eventually gets to the vomiting center. And so rotavirus, serotonin, vomiting center, and causes a lot of vomiting. And so if we're seeing the similar pathway with FPIES, that we're seeing this increase in enterochromaffin cell activity, release of serotonin, and vomiting, could this explain why ondansetron works so well? Ondansetron is a serotonin receptor antagonist. It specifically blocks 5-HT3 receptors. So could this be the mechanism of what's causing the symptoms and why ondansetron is so effective for FPIES? Maybe. So just a quick summary of the pathophysiology. We didn't talk about this, but there are studies that have shown an increase in cortisol activity in patients with acute FPIES. And then at the bottom here, you have all the cells that may be implicated in this process. And then in the top right, you have the enterochromaffin cells and the serotonin release leading to the vomiting reflex through the central nervous system. All right, so last survey question. Do you routinely prescribe rescue medication for home use for pediatric patients with FPIES? This is multi-select, so you can select all of the above, or I guess you can select all the yeses if you want to. I wouldn't select yes and none. Let's give you guys a minute to do that. All right, let's move on here. So yes, oral ondansetron. Some give none. Nobody gives epi. Nobody gives IM ondansetron. All right. Is there data supporting that? So this was a European study that they looked at patients that were coming in for oral food challenges, and they had 66 patients. And we're looking at, okay, those patients that were treated with ondansetron, IM ondansetron, versus those who were given traditional therapy, which is IV fluids, systemic steroids, and what were the outcomes in these patients? So of those patients that received ondansetron, only 19% of them had another vomiting episode after receiving the medication. Great. Traditional therapy, 93% of them had another vomiting episode. Okay, so clearly ondansetron probably makes a difference here. They also looked at the number of vomiting episodes, so 0.5 versus 3.8. They looked at the number of children with pallor or lethargy, 11% versus as high as 78% in the traditional therapies. So I think clearly there are multiple studies like this that have showed that IV and IM ondansetron probably make a difference. But how about oral ondansetron? This is the biggest study of 6 kids. of oral ondansetron. And this came out 4 years ago now. And it's a really small case series in France of 6 kids of 7 oral food challenges that they did for these 6 kids. And they found that 5 out of the 7 resulted in immediate resolution of their symptoms when given oral ondansetron. And if those symptoms persisted despite the oral, they were given IV ondansetron, and everything resolved after that. No kids had subsequent reactions. So with this very limited data, oral ondansetron may be helpful. I absolutely do it all the time. I think it's great. I think it does work, but we just don't have really good data showing that oral ondansetron is effective. There are even cases I've prescribed IM ondansetron to families that are physician or nurse parents who feel comfortable giving it, especially in kids that have really severe reactions in the past. And they've used it and they've done just fine. So I'm not saying don't do this, but there's just very little data here, and we do it at OHSU pretty regularly. So where's the future of FPIES? So I think first and foremost, 2013 was a big year for FPIES, and the first NIH funding specifically for FPIES occurred, and supported to providers NYU and Northwestern, which is huge. But we do have to better define and determine what the natural history of adult onset FPIES is. There's a big gap there. We need more mechanistic studies to better understand the underlying pathophysiology, really confirm the serotonin theory of it through the purine pathway, if that's really what's causing a lot of the symptoms. The development of biomarkers would be awesome. And I think we say that with literally every condition in allergy, is that we need better biomarkers. And hopefully this will happen at some point. So big take-home points. So FPIES, not a rare food allergy, and can be seen in up to 0.5% of children and 0.2% of adults. Early introduction of foods may coincide with higher vulnerability to FPIES. So we're going to see probably more FPIES in our practice because we're pushing earlier food introduction. Atypical FPIES can occur in about 10 to 20% of patients, but its really clinical relevance is unclear. These patients may not necessarily keep their FPIES reaction around longer. We don't know. Adult onset FPIES presents more commonly with diarrhea and abdominal pain compared to children. If you ask patients, they will report this, but we also have a lot of patients that have non-specific GI complaints, migraines, other things to foods that may not fit with this perfectly, but at least keep this in consideration when you're talking to the patients, because you will probably catch a few of these patients. And then serotonin release from enterochromaffin cells in the GI tract may be a mechanism that explains why we get mainly upper GI reactivity, including nausea and vomiting in these patients, and why ondansetron is so effective for these pediatric acute FPIES reactions. The big question I would like to see is if they did that study again, where they stimulated the GI mucosa with adenosine and seeing if they're getting serotonin, if they did it in adults, and see if the colon actually produced more serotonin release, because we're seeing more lower GI issues with adults than we do with pediatric patients. But that hasn't been done yet. This is the word of the day. I don't know how long I keep that up there.
We can leave it up there because people are always asking me a week from now what was it? I don't remember.
All right. Well, thank you. It's my email address. You guys are always welcome to email me for anything that comes up, and look forward to kind of continuing working with the Pacific Northwest here. And I'll leave this up while we do questions.
Thank you very much. We have questions in the room.
Well, is there a role for the gut microbiome which makes serotonin?
Probably. They haven't done enough of those studies yet for us to know, but yeah, probably.
That when treatments based on microbiome get declined, maybe that's
Absolutely. The question was about gut microbiome and how that may play a role in some of the serotonin release, but just the pathway in general. And absolutely, it probably plays some role. We just don't have enough data yet.
Do we have any idea why, even with that limited knowledge of pathophysiology, why there's food specificity in different people?
Yeah. So the question was, do we know why there's food specificity with kind of our basic understanding of the mechanism. And no, I don't think we do, but it seems like it doesn't matter as much of what the food is, it's how early we're introducing it that's playing a bigger role. So that's why cow's milk is still number one. It's probably just because we're introducing it earlier. And so the foods that we're introducing earlier are the ones that are more implicated, and why it's not as common as one specific food is more likely to cause FPIES, but it's just how much we're introducing it and how frequently we're introducing it and how early we're introducing it probably plays a bigger role than the actual specific food.
You know, this story strikes me somewhat similar to eosinophilic esophagitis.
Mhm.
If you go back in the history, at first the question was this disease always there and we didn't know how to recognize it because we didn't have the right kind of scope? Or is it actually increasing in its prevalence? And it seems to me the same story here. Was this disease always there and we just called it, I don't know, viral gastroenteritis or something? And is it increasing? And your suggestion is, yeah, with early introduction since the LEAP study, not only was it there, but it's actually, we're increasing it by what we're telling parents to do. That's what you would say?
Yeah. So the question was, this seems like a very similar pattern as EOE, where EOE was probably always there and we're just recognizing it more and more at this point. And is FPIES really increasing in incidence at this point, or are we just recognizing it better? And I think it's probably a combination of both. I do think in the US, we're introducing foods earlier, right? If you look at the world, a lot of countries introduce solid foods at a much younger age than we do in the US. So I think we're seeing this increase because we are pushing this from a policy standpoint and a recommendation standpoint. So I think we'll probably understand that question a little bit more as it evolves, because we're still kind of in this early stage of earlier food introduction and actual implementation, right? The guidelines have been out for 9 years now that we should be introducing foods earlier, but really implementation is just happening in the last few years. So we'll probably know a lot more when we look back at 2020s onward. We have one question on here, then we'll take that. Anyone there diagnosing and managing chronic FPIES in adults? Asking because of a very interesting consult I saw yesterday. I've diagnosed it a few times. Most of the time in these patients, I'm just telling them to avoid it, and because we don't really know when they may outgrow it, and most adults are totally fine with that because it's pretty easy to avoid fish and shellfish in general, and so they just choose to avoid that because they don't want to feel terrible. But that's all the experience I have with it.
My question or comment along similar lines, in adults, it seems difficult to distinguish between FPIES and what we call food intolerance. And I wonder also, as you pointed, I still wonder, is there a difference between the childhood and adulthood?
Yeah. The comment was just looking at adult FPIES and how to differentiate that between with food intolerances, and is there really a difference between acute FPIES and pediatric and adult populations, and more to come, and hopefully we'll have some answers in the next few years.
You see the evolution of a diagnostic test for this in the near future, or
No.
it's just given my dance trying to get better, you got to diagnose?
Probably. I don't see there's no clear biomarker that's happened, but again, now people are recognizing that there's importance to it. And so NIH is actually providing funding for it. There's just no big push from pharma in this world. But so I think it's going to be slow going, and I think it's going to be a clinical diagnosis for the foreseeable future. The question, sorry, was, do we see a diagnostic test happening in the near future? I don't think so.
With acute adult onset FPIES, was there any information about the frequency or prevalence of those foods in the diet prior to the reaction?
No, they didn't. So the question was there any data on the prevalence of the foods that these patients developed acute FPIES to in the adult setting before they developed the reaction? There wasn't anything in the 2 studies I looked at. There may be another one I might have missed, but in general, it's food that it's a kind of all over the place. Some patients, I think, were eating it pretty frequently, and some patients were eating it very intermittently. But I don't think there's any rhyme or reason, at least that we know about yet. That's a great question.
Is there any evidence of an inherited or heritable component, because milk, of course, has been uniform in its introduction. So
Mhm.
is there any history that correlates between an infant and their parent?
Yeah, the question was a genetic component, if there's any association between parents and children with FPIES. And no, I think adult FPIES is so new at this point that there's just not enough patients to really do that correlation with yet. But I think we'll learn more over time. But right now, no, there doesn't seem to be any rhyme or reason. Yeah.
For the more classic FPIES, would you comment on the cancer patients on introducing other foods like
Yeah.
lunch,
Yeah, sorry, I took that slide out because I was like, this is going to take too long. Yeah, so the question was, how do you counsel families on food introduction after they've had a positive FPIES food in the child? And I think it really depends on the family. Some families are terrified for food introduction. Some families have already introduced a bunch of foods by the time you see them with their history. And so I think based off of the family's anxiety level, I am more aggressive or less aggressive. And so you find those tables all the time that are low risk, medium risk, high risk foods for FPIES. And so in general, I'm like, just start all the low risk foods. And most of those, I don't tell them to like do it for 2 or 3 days. I'm like, just give it to them. And if they do fine, move on to the next food. Like this doesn't need to take 6 months to introduce 10 foods. And then when they get to the medium risk foods, we're a little bit more cautious, maybe introducing 1 new food a day. And then high risk foods, maybe one new food every couple of days. And they usually get to it. Some families find that really too prescriptive and they get really bogged down by that. And so you have to kind of keep it open in that sense. And when we look at these co-allergy situations, because we're delaying the high risk foods till a little bit later in life, they're less likely to probably develop an allergy to it in the first place. So I really push, let's open up the diet as much as possible, get all the low risk foods in really quickly, most of the medium risk foods in really quickly. And then the high risk, we're a little bit more cautious about, but that's really dependent on how anxious the family is.
Has been any reported fatalities from FPI reactions?
So yes and no. There are a couple of case reports of possible fatality to FPIES, but there seem to be a lot more confounding factors in those situations. So pure FPIES fatality, unlikely, but there are a few case reports of there's some stuff going on at the same time. Like could there also have been an IgE component or something else? And they also had, a lot of these kids had other comorbidities as well. So I think there's a handful, we're talking like 2, and both of them were not completely clear. So it's not really considered a fatal FPIES. FPIES is not considered a fatal allergy. All right.
Thank you very much.
Of course.
Obviously, a disease in